So, welcome to Hamilton's Vital Signs. I'm Terry Cooke, CEO of the Hamilton Community Foundation, and as always, we're coming to you live and in color from my living room during these unusual times. My guest today is Dr. Tim O'Shea. Tim, thanks for taking the time to be with us. You are an associate professor of medicine at McMaster University, and also a co-founder of the Hamilton Social Medicine Response Team. So let's cut right to the chase. I always like to start with some biographical detail. Tell us a little bit about where you're from, how you came to do this work, and a little bit about the underpinnings of your passion for community and medicine.
Sounds good. Thanks, Terry. Yeah, so background-wise, where am I from? Did most of my growing up in Barrie. My dad was in the military, so we did move around a little bit, but settled in Barrie for most of my kind of growing up years, and then went from there to Guelph to do an undergraduate degree, and then came to Hamilton in 1999 to do medical school, and I've been basically in Hamilton since then. The background in terms of the work, so medical school, 1999 to 2002, and then did a residency program in internal medicine, followed by a fellowship program in infectious diseases. And through medical school and into residency, really my passion at that point was more international or global health. I was involved in work overseas through some partnerships that McMaster has primarily in Uganda, and then expanding from there into some Latin American partnerships in Guatemala, as well as some Southern African partnerships. And that was mostly focused on medical education, training doctors and other healthcare professionals in other locations. And that really, again, was kind of the career track that I was on initially. So I was working in those areas as well as working here in Hamilton. I started my initial work in the hospitals was at McMaster Hospital, and then when that switched over to Women and Children's, I moved up the hill to the Juravinski Hospital, where I was looking after patients on the internal medicine wards there, as well as doing infectious disease consultations. And through a series of different sort of steps and different kind of things that popped up into my career, the focus changed really from overseas to a little bit more focused on the community here in Hamilton. That was a bit of circumstance of family and that type of thing, and having young kids around, which made it a lot harder to travel. But also,
That'll happen.
I think
That'll happen.
Yeah, for sure. Yeah. Also definitely informed by the work that I was doing on the wards at the hospital, where a lot of what I was seeing was really excellent care provided for a lot of conditions. And I think one of the things I like to sort of underline, because a lot of what I talk about ends up sounding like criticism of the healthcare system. I really do like to underline the fact that I think here in Hamilton, we have world-class healthcare. I think for a lot of conditions, again, I've traveled in many places in the world, including did some of my training in the United States. If you had a heart attack today, if you got hit by a car or something of that nature, there's really nowhere in the world where you would receive better care than here. And so I was experiencing that in the hospitals and seeing a lot of really excellent care, but also seeing a lot of people who really, for whatever reason, weren't able to access that care. And so they were falling through cracks in the system where their health would suffer because of that. So that led to some thinking about how to fill in those gaps. And then around the same time, there was a bit of a crisis in refugee healthcare, and I got involved in that piece around the time when funding got pulled away from refugee care and the interim federal health program got cut by previous federal government. And so that, again, really underlined that although we have what we think of as universal access to healthcare, that the access is really different for different populations in the community. And so there was sort of those group of factors that led to the formation of this program called HAMSMaRT that got started up by myself and Dr. Christian Craker in 2016. It was a bit of an endpoint after a whole bunch of different steps, although not really an endpoint because it continues to change up until today as well.
You've bridged into politics, so I've got to grab it and push you a little bit, because actually, like you, I've spent part of my life growing up on the other side of the 49th parallel, and as you've observed, if I had to choose, particularly in a medical emergency where I'd rather be, it'd be on this side of the border. But we're not immune from the global forces, and certainly not from the political forces that are buffeting the United States right now. And as we speak, we're in the middle of a pandemic, and obviously also being affected by Black Lives Matter. And it occurs to me that medicine's not immune. In fact, is very much a function of public policy decisions we make about the allocation of resources and who counts and who doesn't. Just reflect to me on how current events are factoring into the work that you're doing on a granular basis at the front line, because clearly folks in your situation are both advocates and champions as well as practitioners.
Yeah, I mean, I think again, when we formed the Hamilton Social Medicine Response Team, or HAMSMaRT, it was designed to try to help fill in the gaps created by a lot of the policies that are in effect that end up disadvantaging some populations over others, particularly from our interest's sake, as it pertains to access to healthcare. And we saw that in a number of different ways, and really the places that we really ended up focusing on ended up being around mental health, addiction, and poverty, and how that influences people's access to healthcare. But certainly you see it in other areas like race, like mental health disease, like even things like mobility, where we expect people to be able to come to appointments and get up the hill into the Juravinsky and get down to clinic appointments. We don't really think about what that actually means for people. So I think there is a lot to talk about how policy affects people's ability to actually access the healthcare that we've built up, this great system that we've built up that's able to really keep people healthy, make people healthy when they're sick. Not everybody's able to access that because of different policies that are in place. And certainly as we talk about the COVID pandemic, which is what's on everybody's mind at this point, that has done quite a bit to exacerbate those differences. So the differences, I think, were already there. But the pandemic has made them more difficult to overcome. And in my work, the work that I focus on at this point, again, is around addiction, mental health, and poverty. So people who had a difficult time accessing healthcare because they had to, they had to take time off work or pay money to get transportation to the hospital, or for whatever reason to be able to get to a clinic site. That's become harder with the pandemic because things have shut down. And the other piece has been, for us, is recognizing that oftentimes our priority, which might be treating said infection, is not necessarily the top priority of the patient who's thinking about, how do I get food for my family? How do I get food for myself? Where am I going to stay tonight? And the lack of services because of the shutdown of services related to the COVID pandemic have made that more stark as well. So a lot of people are a little bit lower down on that hierarchy and dealing with basic needs rather than thinking about, okay, my hypertension or my diabetes or my chronic health problem that might not be in the front of my mind right now because I have so much else to deal with.
So I want to drill down a little bit into that. And when you talked about the political dimensions, public policy dimensions of this thing, I'm also reminded of how instructive the work was of the Specs Code Red series, where we looked at just extraordinary differences in life expectancy and all kinds of other clinical outcomes based on income and neighborhood and postal code and all that kind of stuff. And that clearly is related in a very significant way to the work you're attempting to carry out. Talk about how the pandemic has changed the nature of the actual interventions that you're carrying out, and how it's made it different and perhaps more challenging.
Yeah, so I think there's been some positives and some negatives. I think the obvious negative right off the top is that a lot of the services that I was providing and the places that I was seeing patients are now closed. So I just don't have the physical space to meet with people. And our services were built up around places in the community where my patients were already existing. And so we would partner with organizations that already were embedded in these communities where people felt comfortable already, where the barriers were quite low. And that was huge in terms of just our ability to connect with patients. And now, again, that just suddenly disappeared on one Friday when suddenly everything shut down. Yeah. So that's been the major barrier for me in terms of still providing care. In most of my hospital work, I've been able to pivot to doing things over the phone, reaching people by video, using technology to do that. But for many of my patients from the HAMSMaRT program, being able to have a phone is something that they're not always able to do. So we've been able to be creative and certainly stay in touch with most of the patients, but there are some that we just don't know where they are, and which is obviously extremely concerning, and something that often keeps me up at night wondering what's happening to people. So really, again, a lack of space, a lack of a place for people to just be and to exist and to gather, I think, is a huge barrier.
Can you talk? Sorry,
yeah,
I just want to stop. I want to stop you there for a sec, because talk a little bit about the issue of trust and how you build that trust and how partnerships matter. I'd like, because it strikes me as one of the major barriers to accessing marginalized and vulnerable populations would be simply to trust that you have their best intentions at heart and that you're going to act in their interest.
100%. And I think that's, if people ask me what's one thing I've learned by doing this work, I think that's probably the number one thing. I think if we're honest with ourselves in the healthcare community, we have done a very poor job of making people feel comfortable who traditionally don't feel comfortable in a institutional setting, in the healthcare setting. And in fact, I think oftentimes we make that trust worse when people come in through the doors of the hospital, because the patient's already sort of primed to expect that people are going to treat them poorly. And oftentimes a stressed out emergency room, or when everybody's overburdened and they see that, oh, the same person's back again, they're already primed to treat people badly, and it just boils out of proportion. And so for me, I think in trying to be able to provide care to patients like that, the first thing that I had to do was to establish with them, like you said, that I do have their best interests. I'm on their side. I'm trying to come at it from a position of recognizing that there has been trauma caused by the healthcare system, and we need to do something to address that. And the main way to be able to do that was to partner first with agencies that had already established that trust. So places like the AIDS Network, which is where I held my clinics, organizations like the Shelter Health Network that had already been embedded within the community and where the trust was already there. If I was able to piggyback on those relationships, it really did break down those barriers and let me establish relationships with patients. There was a second part to that. Was there a second part to the question?
You actually were going to pivot to the positive of the pandemic experience. So I took you off track.
Yeah, for sure. The one piece around the positives, I think, again, which lays into my second point about trust. I think initially my approach was to partner with organizations that had already worked with the communities. And then the second step to that was actually partnering with the communities. And so finding groups of whichever type of patients we were looking after, where the community was already organized, and being accountable to that group. So saying, I know what my priorities are, but what's your priorities? What are the things that you think we should be working on, and trying to form a partnership like that. And the most successful place that I've seen that happen from my work would be with an organization called Keeping Six, which is an organization of people who use drugs and those that love and support them. And so we've been able to form links with that group that, again, really break down some of those barriers of distrust, where I'm able to work, where the individuals that I work with in that organization are able to say, Dr. O'Shea is a good guy, you can come and talk to him. If they see people that are suffering with whatever issues on the streets, they can say, you know what, I know somebody you can come and talk to. And that really helps people to trust and to come into that group. On the positive side from the pandemic, I think Keeping Six would be an organization I'd highlight that really quickly pivoted their services from a place where they were, again, gathering and meeting in a location that, again, has been closed. But they very, very quickly were able to make that into a mobile service where they're doing outreach in the downtown core multiple times a week, walking around with volunteers, handing out food, and again, just meeting with the community and saying, what's on your mind, what are the needs, what's important to you at this point. And that's been, I think, a huge positive in terms of what they've been able to do.
I want to talk a little bit about the intersection of health and social services. I had the experience over the last couple of years, pre the Ontario Health Teams, of chairing a group that included medical officer of health and the city manager, CEOs of the hospital and the family health team. And one of the things that struck us really early in that work was the extent to which these remained, notwithstanding a fairly interconnected web of services, but two solitudes that the folks in the healthcare system traditionally had thought of themselves and used a particular language, and had less, I think, intimate and trusting knowledge of the folks providing social housing or food security services or a whole bunch of other things. And over time, what we saw was many of the problems that historically have been dropped at the emergency room door, in fact, were much better addressed in other parts of the community. And I just want to talk, I want you to muse aloud, if you could, for us about the evolution of the interconnectedness between what you do as a healthcare practitioner and the dependence and mutual reliance with folks in other parts of the social service ecosystem.
Yep, I think that's, I think you hit the nail on the head there. I think a lot of what we see in the hospital is not primarily due to a biological dysfunction of the body or a disease process, but could be more appropriately traced to some sort of a social or policy failure or lack of resources or whatever it ends up being, that ends up putting people into the hospital. And oftentimes, I think because that we don't have the training that maybe the social service agencies do, we don't do a great job of addressing those particular things, which then leads to that initial problem that I talked about of the same people coming back again and again with the same problems over and over again, and us saying, okay, here's a pill to treat that, which is not what they need. They need a house or they need something else. And the frustration just rises and rises about, why are you back again? Why are you back again? And nothing seems to be getting better. I think when we first started HAMSMaRT, we thought that we could bring, in some ways we thought, okay, if we bring our skills and knowledge in medicine, the problem is more of one of access. So if we bring our skills and knowledge in medicine to people where they're at, we'll be able to bridge some of these gaps and make people better, control some of the chronic diseases that they might have, treat some of the chronic infections, that type of a thing. And I think that we've been somewhat successful in that. We've been able to break down some of those walls and make sure people get the medicine they need or the tests they need or that type of thing. But certainly the overall lesson has been that doing that without addressing the other side, without addressing the housing and the income and the racism and all of the other things that make people sick, we really don't get anywhere. Really, we make very, very small steps. We've got a number of examples of patients that we really kind of pour our hearts and souls into and try again to make them healthier with medicines, with tests, with whatever it happens to be from our toolbox. And we'll go a year, 18 months doing that. And you know, sometimes it feels like we're just barely keeping them alive, which is a good thing. We're keeping them alive, but we're really not making much progress. And then that person will get housing, or they'll they'll find a community that's supportive and they can rely on. And suddenly the switch goes and suddenly things start to get better. So I think that's another kind of key piece to all of this, is trying to figure out, how do we as physicians, how do we as a healthcare system effectively address all of the causes of the disease that we're seeing, and not just the handing out a pill or ordering a test.
And I would tell you, if I can editorialize for a bit, one of my historic frustrations occasionally with friends in your business is their unwillingness to be what they see to be political. And in my view, when you think about the role of, for instance, the medical officer of health, and I've had great conversations with my friend Elizabeth Richardson about this, their purview is not just infectious disease. It's urban design, it's affordable housing, it's road safety, it's access to public spaces, it's a whole bunch of other things. And you, I think, in the role that you're playing with the social medicine response team, have understood that responsibility for advocacy around public policy matters. And you, in fact, are perceived as honest brokers in that conversation who can, in fact, influence outcomes, especially for marginalized communities. So I want to push you on that, because in the limited time we have left, I want to talk about some of the gaps that you're seeing, both exposed by the pandemic and pre-existing, and think a little bit out loud about what we should be thinking about as a community if we want to get better health outcomes.
Yeah, I mean, I think at first, just to address your first point about medical professionals being political, I think there's two sort of camps of this that I've seen within my colleagues, and there's some that will say, you know what, my job is to diagnose and prescribe, and what happens after that is not really up to me. If the patient doesn't take the medicine and they don't get better, well, I've done my job. I've diagnosed and I've given the prescription. And I mean, we could have other healthcare professionals on and have a debate about that. To me, what my answer to that is often that the outcome is really what we're interested in. If we can know everything and prescribe everything, but if the person doesn't get better, then we're really wasting our time.
Right.
And especially in a public system where the taxpayer and the community is putting a lot of resources into the system, it's hard to argue that we should keep on getting more and more resources if really we're not making any difference at all. And I think that, again, the lesson from our experience is that we can't get to those outcomes without being political, without thinking about policy, without addressing all of those other issues. So I do think it's extremely important. Again, the majority of my work right now is done in communities where there's an intersection between mental health, addiction, and poverty. In that community, the main issues in terms of gaps at this point, housing is key, I think. I really don't think that I can make much difference in somebody's health or their life if they don't have a place to sleep at night. And again, I've had conversations with people where we've made a diagnosis and the treatment is obvious, and here's what you need to do to get healthier. And why aren't we taking those steps? Well, I don't know where I'm staying tonight. I'm not, how am I going to expect somebody to show up and meet me at an appointment if their concern is where they're going to sleep at night. So I think housing is the top of the list for me. I think we really need to sort that out and figure out how we get people into housing.
And at scale. I mean, one of the concerns I have is it can't be onesies and twosies. When you look at the depth of the need in that area, in this community, and in frankly every urban community across the country that I'm familiar with, we need a dramatic increase in the commitment to and the expediting of approvals and construction around affordable housing. That I think would do more for medical outcomes than anything else I can imagine.
100%. And I think, you can make the argument that it's just the morally right thing to do. And I think you could also make an argument that there's probably some economics to it as well. The amount of money we spend looking after people for health conditions that arise because they don't have housing is gigantic. And we have, again, lots of examples of patients we've looked after in the hospital who have had 6, 8, 9-month stays in the hospital at who knows what amount of money, when really interventions like these, housing, income, would have made all the difference. Which pivots to the second point, I think, which is poverty. I think that things like the universal basic income, the pilot that was canceled in Hamilton, would have given us really some excellent data to base these types of decisions off of. But outside of the data piece, again, when I'm thinking about my patients and their day-to-day existence and their day-to-day lives, the lack of an ability to get the necessities of life, to pay for healthy food, to have a bit of economic freedom to be able to do the things that they want to do is a huge issue. And then we move into the realm of drug policy, I think, which is a third major issue for my patients. Access to a clean and untainted drug supply, the criminalization of a medical condition like substance use disorders, are the things that, again, don't just make my patients sick, but not uncommonly lead them to die. It's not an uncommon issue for us in the work that we do.
So just expand a bit upon the whole notion of harm reduction, if you could, and safe injection sites, because we tiptoe around it, and yet, as you say, it's a matter of life and death.
It is 100% a matter of life and death. I think, again, my education, and this has been a steep learning curve over the last several years that I've been working more and more in this community. I think the patients that I can say unequivocally, the patients that I work with, who have substance use disorders, particularly those addicted to opioids, it ends up being the main issue in their life, the main priority. It drives a lot of what they do. It motivates a lot of their day-to-day existence. And policies which assume that it's just something that somebody can turn a switch off of and stop just don't make any sense, really. It just doesn't seem to work at all. There needs to be a lot more infrastructure, a lot more support put around it. And so a lot of what we're doing at this point in this organization is minimizing those harms, like you said. So harm reduction measures, making sure that if people are going to use, they have access to clean supplies to use, they have access to naloxone kits in case of overdose, they know how to safely inject, they know how to use in a safe environment with other people. And that's where something like a safe injection space comes into play. We have safe consumption site in Hamilton. The resource is inadequate at this point. I think that it's definitely doing all that it can, the site that we do have, but we need more. I don't think there's any question of that at all. And then I think the other main issue in terms of harm reduction that we don't have in Hamilton that I think is an issue which I feel some personal shame around, because I don't know why we haven't been able to move this, is access to a clean drug supply. Things like injectable hydromorphone or injectable heroin programs that have good evidence basis behind them. There's been good studies that have shown that they're beneficial in terms of mortality as well as people's general health. That data is there, and for whatever reason in Ontario, in Hamilton, we just haven't been able to raise the infrastructure to do that. I often think if there was a similar study in something like heart attacks or strokes that showed mortality benefit, the infrastructure would come.
We'd move it in a heartbeat.
We would, yeah. Especially if it was causing such a high degree of morbidity and mortality in our communities like opioid addiction is.
Yeah. Unfortunately, we are out of time because this is a subject that merits much more time. But Dr. Tim O'Shea, I am so grateful for the work that you're doing, for the partnership with the Community Foundation, for the efforts of the Social Medicine Response Team, and for the difference that your group is making in Hamilton today. You're needed more than ever, and I look forward to continuing in partnership with you, and obviously to continuing this important conversation for Hamilton. Thanks for being with us today.
My pleasure. Thank you, Terry.
And I'm Terry Cooke. You've been watching Hamilton's Vital Signs with Dr. Tim O'Shea from the Hamilton Social Medicine Response Team. As always, you can follow us on social media, Facebook and Twitter. Look forward to having you back again next month. Take care. Be safe out there.